Assalamualaikum and good day. My name is Dr. Mardiana and this is the first part of a two-part lecture on diseases of the vulva, vagina, cervix and uterus. For the first part of this lecture, we will be focusing on the knowledge to describe the risk factors, pathogenesis, morphology, clinical effects and complications of common diseases of the vulva and vagina and cervical carcinoma, and correspondingly the skill of identifying the morphology of cervical carcinoma and its pre-neoplastic lesion. We will start with some common diseases affecting the vulva and the vagina. So the first one, leukoplakia, is not a disease in itself. However, it is one of a common presentation of a disease within the vulva. So as you can see in the image here, obviously this is not the vulva, but you might recall that leukoplakia simply means a white plaque, and we have visited this before in other modules such as the GI system. So it can be a presentation of several conditions, be it non-neoplastic or neoplastic. And examples of non-neoplastic conditions include lichen sclerosis, which is an inflammatory condition, or squamous cell hyperplasia, which is a reactive condition. However, because leukoplakia is quite non-specific, you can't really tell the difference between leukoplakia in a non-neoplastic condition versus neoplastic conditions. So, neoplastic conditions such as VIN, which is vulva intraepithelial neoplasia, extramammary PAGET disease, or carcinoma, these will have to be differentiated from the benign ones, and this is done through biopsy examination. So that's them as an introduction of manifestation within the vulva. So what are other conditions that you can see in the vulva? Condyloma is one important condition, if you like. It is a benign genital wart, and this is due to infection by low oncogenic risk HPV. It can affect many regions in the female genital tract, and morphologically it tends to form this exophytic warty growth with thickened squamous epithelium, sometimes hyperkeratosis, and on higher power we will appreciate some koilocytosis, which represent virally infected cells. So this is benign. This is a benign condition. Extramammary PAGET disease is neoplastic. Okay, it is an intraepidermal malignancy. Often presents just sort of like an eczematous type of appearance of the skin. So very red, kind of scaly, could be quite itchy, not very well defined border, so it's very difficult to delineate the lesion, and as a result sometimes excision of this lesion may not be complete and recurrences are quite common. So histologically what you see though are malignant cells, okay, which are these larger clear cells with clear cytoplasm. They're quite large, voluminous cytoplasm. Here they are confined within the epidermis. So invasion into the stroma is rare, but whenever that happens, it indicates a poorer prognosis. So this is an important condition to exclude if someone presents with sort of an eczematous-like lesion in the vulva. The most important malignancy affecting the vulva and vagina is squamous cell carcinoma. And they share some similar characteristics in that they both have a pre-invasive component or lesion called vulva intraepithelial neoplasia VIN in the vulva and vaginal intraepithelial neoplasia VAIN in the vagina. And this state is comparable to cervical intraepithelial neoplasia, which we will discuss in a moment. In terms of its risk factor and pathogenesis, they differ slightly in that virtually all SCCs of the vagina is associated with high-risk HPV, but squamous cell carcinoma in the vulva may or may not be related to HPV. Okay, so now we move on to the bulk of this lecture, in which we will be talking about cervical pathology. So before we dive in further, there's some abbreviations and terminologies that I would like to make clear. So I'll be using them quite a lot throughout this part of the lecture. So the first one is CIN, which is short for cervical intraepithelial neoplasia, and it denotes dysplasia of the cervical mucosa, and often used whenever we describe histological changes. CIN can be divided into three, 1, 2, and 3. which corresponds to mild, moderate, and severe dysplasia. So that's the first one. So the second one is SIL, squamous intraepithelial lesion, which also denotes atypia or dysplasia of the cervical squamous mucosa. It is often used to describe cytological changes, but it is interchangeable with CIN. Right? And it's only two-tiered classification, and this is a newer classification because it reflects the management, because the management for low-grade lesions are different than management for high-grade lesions. So low-grade SIL is equivalent to CIN1 or mild dysplasia, while high-grade SIL is equivalent to CIN2 and 3, which means they are much more severe and therefore they have higher risk of progression to cancer and they are managed differently. The third abbreviation is HPV, short for human papillomavirus, and this can be further divided according to the risk of associated progression to malignancy, and the division is as such: low risk HPV, HPV 6 and 11 are examples, and they have low risk of progression to cancer, and high risk HPV, there's so many of them, but the most common would probably be HPV. Not probably, sorry, the most common are HPV 16 and 18, which account for around 70 to 80% of all high-grade squamous intraepithelial lesions and also cancer of the cervix. Okay, so CIN, SIL, and HPV. Okay, so CIN, cervical intraepithelial neoplasia, or its other name, squamous intraepithelial lesion, SIL, and cervical carcinoma will be discussed together, because obviously this is a precursor to this, therefore they share the same pathogenesis, they share the same risk factor, so it makes sense for us to discuss it together. So the most common type of cervical carcinoma is squamous cell carcinoma. There are other types, but for the purpose of this lecture, we're going to focus on squamous cell carcinoma. This is preceded by a pre-invasive dysplastic state called CIN or SIL. The pathogenesis for the development of CIN or SIL and subsequent cancer relies heavily on the role of high-risk HPV infection. Okay, so as such, there is a set of risk factors which are associated with the development of the disease. So there are risk factors which result in someone more likely to acquire high-risk HPV infection, and there are also risk factors that result in someone to progress from having the high-risk HPV infection into the higher grade lesion and cancer. Another point worth mentioning is that this is a very predictable flow of disease, from risk factor to infection to formation of dysplastic state and also progression to cancer. This is quite predictable in most cases, and it also takes a long time from point 1 to point 2 at the end here. So it provides a window for screening for pre-invasive states, which we will also touch on, and also because we have a known etiological factor here, which is the high-risk HPV infection, it also creates a window for prevention, as you know, which we will also discuss in a moment. So that's an overview of the flow of lecture of CIN, SIL, and cervical carcinoma. So let's discuss the pathogenesis and risk factors for the development of CIN and subsequent cancer. So where does the infection and also the disease take place? This is often at the region in the cervix called squamocolumnar junction. Okay, so this is here, and squamocolumnar junction is the area where the ectocervical squamous mucosa or epithelium meets the endocervical glandular epithelium. So it's squamocolumnar junction. But this is a dynamic region where metaplastic process constantly takes place, and the metaplasia occurs. It's a transformation from endocervical glandular into the squamous epithelium. So as a result, because of these constant transformation, etc., there's a lot of immature epithelium present there. And HPV likes immature epithelium. So this is where they tend to go to, right? So high risk HPV infection, low risk can also go, but for the purpose of today's lecture and carcinogenesis, high risk HPV infection, especially 16 and 18, they tend to infect this region. Okay, so because high risk HPV infection is a known etiology for the development of CIN and dysplasia, then risk factors for CIN and dysplasia relate to risk factors or behavior that increases the risk of acquiring or getting the infection. Okay, if that makes sense. So for example, if someone has multiple sexual partners, or if they have a male partner with multiple previous or current sexual partners, this increases the risk of getting exposed to HPV and getting the infection. Again, if someone was at a young age at first intercourse, or if someone has a positive history of sexually transmitted diseases, this also increases the risk, and partly because this would indicate a promiscuous behavior of that person. However, genital HPV infection is actually very, very common, but most of the infection is transient. So the body will clear the infection by itself. So after a few months or maybe a year or two, then infection just goes away in the majority of individuals. But in some proportion, in some women, the infection will persist, and it is the persistent infection that becomes a risk of progression to cancer. So there is another set of risk factors which can be associated with progression of HPV infection into developing high-grade lesions. Okay, so point number one, if someone has a persistent infection with high-risk oncogenic high-risk HPV, then they are more likely to develop high-grade squamous intraepithelial lesion as well as subsequent cancer. And persistent infection means the body can't clear the infection by themselves, or perhaps a repeated kind of infection if someone has exposure to multiple types of HPV, or repeated infection with the same serotype of HPV, but this is all persistent infection and it increases the risk. Secondly, if someone has a suppressed immunity, HIV is a known cofactor in this. That's a lot of patients with HIV who has HPV infection tends to progress into high-grade lesion as well as cancer. But even if someone has poor nutrition or have systemic diseases on immunotherapy such as systemic lupus erythematosus, etc., so these are also states of immunosuppression that favors progression to high-grade lesion and subsequent cancer. And cigarette smoking, as you know, is a factor in many cancer, not excluding cervical carcinoma as a cofactor, because cigarette smoking also reduces immunity, but it also contains carcinogens that can get concentrated in the cervical mucus and again favor the progression to squamous cell carcinoma of the cervix. So once someone gets a HPV infection, so I mentioned earlier how majority of HPV infection is actually transient. So a lot of them gets cleared, but only some will actually progress to form high-grade squamous intraepithelial lesion and subsequent cancer. So how does the cancer develop? How does this high-grade lesion and cancer develop in the setting of HPV? So first of all, you must have the HPV infection. Okay, so that is the etiology. And a lot of studies will quote that it is a prerequisite for the cancer to happen. So HPV infection happens at the basal epithelium or the immature squamous cells at the transformation zone, that dynamic area where the metaplastic process occurs. So there's a lot of immature cells there, or in other squamous epithelium if there is any break in the surface, so that allows access of the viral particles to go into the immature basal layer. So HPV infection occurs. So HPV DNA can be, once they enter the cells, the HPV DNA can stay in episomal location, where when that happens, it results in viral replication to occur in the mature cells. The viral replicates. But this episomal location of the HPV DNA seldom causes anything severe. At most, they will produce low-grade squamous intraepithelial lesion, and therefore we say they don't really have the capability to induce formation of high-grade dysplasia or invasive carcinoma. So I'm going to remove that from the equation. But for the development of high-grade dysplasia and subsequent cancer, it requires integration of the HPV DNA with host DNA. So I just want to highlight here, if you can see that this is the HPV virus here, and you can see that within the HPV virus there are two viral oncoproteins which play a central role in the development of high-grade dysplasia and cancer, and these are the E6 and the E7 viral oncoproteins. So after integration of HPV DNA with host DNA, these E6 and E7 viral proteins can bind to the host cellular P53 and RB. So you know these are tumor suppressor genes, and the binding of E6 and E7 proteins to these tumor suppressor will inactivate these tumor suppressor genes, and they result in two things. The binding to P53 will prevent cell cycle arrest, so the cell will continue to proliferate, okay, all the way up, and also prevent cell death, so immortalization of the cells. E7 binding to RB also produce the same thing, so prevent cell cycle arrest, and on top of that, it also impairs the ability of the cells to repair DNA damage. So now imagine a clone of cell population which will just not die and keep proliferating, and on top of that they may have DNA damage, so the cells that are proliferating are also abnormal. So what you get is a net effect of increased proliferation of cells, but these cells are also abnormal, so they have the potential to acquire additional mutations and subsequently progress to cancer. So let's just recap that very quickly. So how does HPV exert its carcinogenic effect? Essentially the pathogenesis of high-grade dysplasia and subsequent carcinoma. So number one, you need the HPV to infect the immature basal cell or immature squamous cells. And then you need the integration of high-risk HPV DNA with the host DNA. The HPV's carcinogenic ability depends very heavily on viral E6 and E7 protein, and they bind to P53, inactivates it, prevents cell cycle arrest and immortalization of the cells. E7 binds to RB, inactivates it, and prevents cell cycle arrest and impairs ability to repair DNA damage. So this is a net effect that you get, and there is of course additional role of cofactors such as presence of co-carcinogens like smoking we mentioned earlier, or reduced immunity. So these are all states within the body that will assist in the progression of dysplasia into subsequent carcinoma. Briefly on the natural history of CIN or SIL, I just want to highlight here a couple of things. In that, first one is even with someone who has developed LCIL or CIN1, you can see that only a small proportion will progress to a higher grade lesion. So of these population, about 10% will progress to high grade, but a majority of them, about 60%, can actually regress. And even if someone has developed high grade squamous intraepithelial lesion or CIN2 and 3, of these, only 10% will progress to carcinoma, whereas the majority will persist, and around 30% still has the potential of regression. And this is actually the natural history of the disease within 10 years, so providing a very predictable flow and a long period of time for intervention. And this is the schematic representation of the progression from low grade to high grade and subsequent invasive carcinoma. So I mentioned earlier about how the episomal location of the HPV DNA is already allowing the virus to replicate within the mature epithelial cells, and this has a very characteristic appearance under the microscopy. So this is squamous epithelium of the cervix. Okay, so this is the basal layer and this is the superficial layer. The cells that contain lots of replicating virus will produce an appearance called coelocytic change. So these cells are called coelocytes, and they are concentrated in the superficial part of the epithelium, and they have a characteristic enlarged but wrinkled nuclei. Sometimes people call it raisinoid, looking like raisins, and they also have perinuclear clearing or halo. So when you see this, you know that this is a HPV infected cell, as these are the characteristic changes. In terms of morphology of CIN, so CIN 1, 2, and 3, again, low cell. These two are high cell. And compare that to normal. How do we decide it's actually CIN 1 or 2 or 3? It's actually based on the degree of dysplasia or the degree of expansion of immature basal layer from its normal location. So first we divide the epithelial thickness into 3, okay, lower 1/3, lower 2/3, and upper 1/3, and then we assess how much dysplasia is present and where the dysplasia is present. So for CIN 1, okay, the dysplasia or the immaturity of the cells are localized to the lower 1/3. So up here you can see some enlargement of the cells, enlargement of the nuclei, but you can also see some nuclear clearing, perinuclear clearing surrounding them. So that is coelocytes, coelocytic change. So these are coelocytes, okay. So that's CIN 1. For CIN 2, the dysplasia actually involves the lower 2/3 of the epithelium. We can still see some coelocytes present on the upper part, but for CIN 3, you don't see coelocytes anymore. All the cells look the same from bottom to top. So this is now complete lack of maturation or full thickness dysplasia. So the nuclear atypia that are present are characterized by enlargement, hyperchromasia, coarse chromatin, some variation in nuclear size and shape, some disarray, and haphazard arrangement as well. But another point to make is that if you look at the bottom, that the basal membrane is intact in all cases, okay, and this is especially important when you're dealing with high-grade dysplasia, because when you have intact basal membrane, then you know that there is no invasion into the stroma. Okay, so again, another image on CIN 3. Full thickness dysplasia, very haphazard arrangement, very hyperchromatic and atypical looking cells, as you can see here. And on the right hand side, just want to highlight suprabasal mitosis, which is another feature of high grade dysplasia. So mitosis in normal situation should be confined in the basal layer or the basal part of the epithelium, because that's where the normal proliferative activity is. But because you have inactivated the apoptotic mechanisms, you have also prevent cell cycle arrest through the action of E6 and E7 earlier, then even the cells up here can now proliferate. Okay, so they will divide and they undergo mitosis, etc., as highlighted here. Okay, so we have discussed the risk factors and pathogenesis up to the point of development of high-grade dysplasia. So with progression of that, the patient will develop invasive cervical carcinoma. So invasive cervical carcinoma, as a general term, can refer to any histological subtype of these. Squamous cell carcinoma is the most common. The incidence peaks at around 45 years of age, and as we have discussed, HPV infection is a prerequisite that leads to development of SIL, the pre-invasive lesion, and then with further accumulation of mutations, then the patients progress to form carcinoma. So some gross morphology of cervical carcinoma, it can form exophytic growth. Okay, so this one is quite localized. Sometimes they can be really, really large when advanced like this. They can have surface ulceration, erosion, and that can explain some of the clinical manifestations.
So invasive squamous cell carcinoma, as I've always mentioned, squamous cell carcinoma is squamous cell carcinoma wherever you see it. So they will form a typical squamous epithelium, typically in islands, and they infiltrate the stroma. There's often a desmoplastic response associated with it. And how do you tell that it's squamous? You will see evidence of squamous differentiation in the form of keratinization. And if you have higher power, sometimes you will also see intercellular bridges in between the cells. This one is quite inflamed. You can see a lot of inflammatory cells in between as well. And occasionally you will be able to see the CIN changes, the dysplastic changes on the surface adjacent to the invasive component. But it's not present here, but sometimes you can see it. Okay, so straight into the clinical manifestations, cancer spread and complications of cervical carcinoma. So cervical carcinoma obviously begins at the transformation zone, as I've mentioned. So it can go up, it can go down, it can go sideways. Okay, so via direct extension, it can extend into any of the contiguous tissues. And these include paracervical soft tissue. They can involve the urinary bladder, okay, going up to the front there, or it can involve the rectum, going posteriorly. It can involve the pelvic wall, okay, so including the bones as well surrounding it. So it can go down into the vagina, it can go up to involve the uterus. Can also involve the ureter, which obviously lies quite close to the ligaments near the cervix. So what can it cause? If it involves the pelvic wall, then the patient can present with pelvic or bone pain. Involvement of the urinary bladder can lead to bleeding or fistula formation, even though uncommon. Rectum is the same, can have fistula formation and bleeding. And involvement of the ureter is very important because it can cause obstruction of the urinary flow, and then patients can get problems such as pyelonephritis, infection of the kidney. They can get dilatation, structural changes, hydroureter, hydronephrosis, and then with subsequent destruction of the renal parenchyma or very severe obstruction, patient can get renal failure and uremia. And this is actually one of the fatal complications of cancer spread, of cervical cancer. So that's direct spread. Lymphatic invasion can happen, as you know, and also distant metastasis to other sites. So the presentation and complications can depend on where the metastatic disease has gone to. So again, note that most patients die of local complications, which is of direct spread, rather than metastatic disease. So what are the clinical presentation? This mirrors the extent of disease that is present. So just to remind you that especially in the pre-invasive state, the SIL and CIN, they're often asymptomatic and they're detected through screening, which is a reason why screening is so important, because even with high-grade dysplasia, patient may not have any symptoms. So they don't know. They're happily harboring their pre-invasive states and not knowing that they have it. So screening is very important. If cancer has developed, then it depends on the stage, okay, how extensive the cancer is, so that can reflect the presentation. Most patients will present with abnormal vaginal bleeding, usually post-coital, because obviously the act of intercourse can actually cause erosion and ulceration and localized bleeding from the tumor. Patients can also complain of vaginal discomfort, dyspareunia, because of the presence of a mass. Malodorous discharge can also be a problem because tumor, especially if they're quite large, they tend to be necrotic. And then these necrotic areas can become secondarily infected, and that can produce this unpleasant discharge and odor. And of course, if the cancer has spread, then it can have complications and presentation relating to that, as some of it we have mentioned earlier. If someone has developed fistula, then they can pass either stool or urine through the vagina because of the abnormal connection. So either rectovaginal fistula, rectocervical fistula, etc. And of course, patients can present with features of renal failure, and they can also have symptoms associated with with metastases and also non-specific features of advanced malignancy. So clinically, just a few points to mention. The flow of management of patients are typically starting with screening if they have abnormal findings, and they're referred to colposcopy and biopsy for confirmation. They can undergo several management options, surgery, as well as radiation or chemotherapy. Prognosis very much depends on stage and type. So obviously the more advanced disease will do worse, but a localized, small invasive focus can do quite well, and death is usually due to local tumor invasion. One slide on prevention and screening. So you know that prevention now works in the form of vaccination. HPV vaccination is now routine, and that will help prevent infection by the high-risk HPV. Screening is done to detect the abnormal cells in the pre-invasive state, and screening now takes two forms. One in the form of cytological examination of the pap smear, where you sample the transformation zone of the cervix and the cells are examined, and if there's any abnormality identified, then they can be referred for subsequent investigations. And another form of screening is doing HPV DNA testing. So the same sample can be subjected to DNA testing, and if you detect any high-risk HPV DNA present, then the patient will be managed accordingly. So a quick summary of what we have discussed. So we have discussed the pathogenesis of CIN and SIL with its subsequent squamous cell carcinoma or cancer progression. We have discussed the pathogenesis of that in terms of the role of HPV infection and the risk factors associated with the acquisition of HPV. Now we know that HPV infection can be transient in many, and only some progresses to develop dysplasia and squamous cell carcinoma, and this requires HPV integration with host DNA, and in the presence of persistent infection and also other cofactors such as reduced immunity. We know also in terms of the natural history of low-grade and high-grade squamous intraepithelial lesion, which with progression of disease and development of cancer, we have now discussed their clinical features, complications, including the spread of the disease. We've discussed the morphology of the dysplasia as well as invasive squamous carcinoma, and on top of that, we have also mentioned the prevention method as well as screening methods for this disease. A quick recap on the disease of the vulva and the vagina. We mentioned of the common presentation, which is leukoplakia, and we mentioned we discussed a few common conditions such as condyloma, extramammary PAGET disease, and squamous cell carcinoma. And similarly in the vagina, also squamous cell carcinoma, in which they share some similar characteristics of the preceding cancer, in pre-invasive state of the cancer, and also some of the risk factors. So that's the end of part 1. So these are the references that I use, and we'll see you all in part 2. Thank you.